Hello everybody. Good afternoon and welcome to my place of work, Leeds Beckett University. My name is Chris Hudson. I'm Associate Dean for Research and Enterprise in one of the faculties here. I've got a couple of domestic arrangements to run through with you before we get into the programme proper. You can see for yourselves by looking around the lecture theatre here, which we've had to change to accommodate the vast numbers of people from across the city who are interested in attending today. And I don't think it's an exaggeration for me to say we're going to witness a presentation regarding what I believe is going to become a seminal study, not just for the city of Leeds, but for men's health within the UK, as this is the first of its kind. It's obviously a real proud moment for anyone from the university, my colleagues Alan and Amanda who will speak, who've undertaken the work to engage in something which is hopefully going to have tremendous impact and provide some real benefits for our city. Before we get into the programme proper, I am just going to remind you all, you've all got one of these in your pocket, and if you're going to take pictures or film, that's absolutely fine. You can talk to their agents here. But make sure it's switched off, please. That would be great. There's not going to be a fire alarm test. The doors are behind you up the stairs, and then, as you can see behind me, at either side. I understand we're going to try and keep it to a strict hour for the programme because the mind can't comprehend what the bottom can't endure. So we'll see how we go. Without further ado, I'd like to, first of all, thank the City's Director of Public Health, Ian Cameron, for having the foresight and the energy to commission this piece of work, and I'd ask him to come up here and make his introductions. Thank you, Ian.
Well, thank you very much, and it's great to see so many of you here today. Today is the start of Men's Health Week, and it's wonderful that we can launch the report on the state of men's health in Leeds today. It is a very good report, it's a very challenging report, and it really sets out where we need to go in Leeds. And as Chris said, it is great for Leeds that this is the most comprehensive report that's ever been done on men's health in any city in our country. It is also an example of partnership working between the council and Beckett University, but also we've had fantastic support from the clinical commissioning groups and also the third sector, and these are the sort of partnerships we want to continue in the future. We've been very clear from the beginning that we did not want this to be a report that just sits on a shelf and gets dusty. It is very much directed towards commissioners but also providers, and we're certainly committed as a council to making sure that we use this report in a whole variety of fora and also our future commissioning arrangements. Finally, I just want to say that we will use the report in contracts in the future as a council, and we will be working with partners to do the same also. We will make sure that copies of the report are available to you. At the end you will have the summaries, but we'll make sure at the end that you can have all the details so that you can access the full report. Now, for the running order of today, we're going to begin with Councillor Charwood from Leeds City Council. Councillor Charwood is the Executive Member for Health, Wellbeing and Social Care, and importantly for the purpose of today, she is the Chair of the Health and Wellbeing Board, and Councillor Charwood is going to be talking to us about the Health and Wellbeing Strategy, which sets the context for the report that you see there. We're then going to follow with Alan and Amanda, who've done all the good work, and they're going to share with us some of the findings, and we've been extremely fortunate to have their expertise on this report. After that, Chris will make a reappearance, thanks to popular demand, and come and host a Q&A session for us. And as Chris said, we are going to keep to time. And importantly, there will be refreshments at the end of the meeting, and there'll be a chance for more networking. So to kick us off, I'm going to ask Councillor Charwood just to come and say a few words on the Health and Wellbeing Strategy.
Thank you very much, Ian, and thank you to everyone who's here today for coming. And I'm delighted to be here at the launch of this report. It's a really important report, and it's a very interesting and informative document. I'm going to keep it very close by in the next year while I'm learning the ropes in the Health and Wellbeing Board. It's a fantastic resource, and it's really well laid out. So thank you, and well done to the authors of the report as well. I just want to take a moment to pay tribute to my predecessor, Lisa Mulheron, who is councillor and also the chair of the Health and Wellbeing Board. She's just left the role as executive member to become the executive member for families and children, which is a really big area and a new exciting area for her. But she's had a huge amount to do with this as well. So I'm taking on after her wonderful work, and hopefully I can build on the partnerships and the good work that she's already done. So this report is about why men's health matters and how men's health can be better. And soon we'll be launching the new Health and Wellbeing Strategy, which is the city's 5-year plan for improving health and wellbeing and for reducing health inequalities. And that's a really key point I'll come back to. There are, excuse me. There are a lot of common themes between the Men's Health Report and our new Health and Wellbeing Strategy, so I'm just going to highlight 4 key areas which we'll be championing as the chair of the Health and Wellbeing Board. The first is that health is unequal around the city. There is a 10-year difference in life expectancy from Hunslet to Harewood, which is the biggest challenge in Leeds, and we need to address the significant health inequalities that exist around the city. This research shows how the length and quality of our lives are dependent on where we grow up and what opportunities we have in learning and employment. It shows how significant the differences are in health outcomes, education, housing and jobs for men in different areas of the city. And it shows that the majority of men's health problems are preventable, which is clearly crucial. That people live 10 years less than others depending on where they live is fundamentally not fair. It's wrong and it needs to change. Because lots of problems are preventable, they can change, and that's why the vision of the Health and Wellbeing Board is that people who are the poorest will improve their health the fastest. And we're committed to keep a relentless focus on that aim. The second area I want to focus on is the fact that everybody is different. We're all different. One of the things which makes Leeds great is our diversity. We have different backgrounds, different values, different ambitions and different motivations. Because of these differences, we view and manage our health in very different ways. For example, this weekend some people joined in with a triathlon and others may not do. But this report shows us how men and women are different. And our challenge, therefore, is not to treat everyone the same or purely on the basis of them being male or female, but that everybody is an individual as well as that. But this report really draws out the key broad differences between the genders, which is very useful. We need health and care services which are person-centred, sensitive to their needs and values as individuals. And that's why our new Health and Wellbeing Strategy makes commitments about person-centred care. The third area I want to focus on is thinking about the whole person. In addition to everybody being different, I really welcome how this report shows that we have to think about all of a person's needs and the many factors which may be influencing their health and well-being. So this means integrating mental and physical health. It's really important. Addressing the physical health needs of those living with mental illness and always considering the mental and emotional needs of those with physical illness. Having started my career as a mental health worker, I'm really passionate about that particular area of work and very particular to men's health with the suicide rates that we've heard about. And it also means thinking about all the wider things that influence our health. So the places we live, the people we work with, the education we receive, the money we have. We know that the health of men is inextricably linked to the context in which they live their lives. So our new Health and Wellbeing Strategy makes commitments about improving housing and the environment, creating a strong economy with quality local jobs, and building communities which are well connected and very positive places to live in. The fourth area I want to focus on is building on positives. There is a lot of brilliant work that this report has highlighted that's already happening in Leeds. Leeds Dads, Space 2, Men in Sheds, York Street Practice, to name a few. And when we take a positive perspective on the strengths in men's lives, We consider how they contribute as fathers, as friends, as brothers, as workers, people with talents and gifts. We can then start to think about what is strong and that we can build on, rather than treating the problem or what needs fixing. And this is how we're going to become the best city in the UK for health and well-being. We need to build on the strengths and assets in individuals, their families and their communities. So just to conclude, I want to really welcome this report and the perspectives it gives us on men's health and on their lives, and more generally about well-being in Leeds. It's a really interesting read, and I'm sure, like I said, I'll keep a copy really close by to refer to as I'm learning my new job. And I really would welcome a similar analysis on women's health as well, which I think is really, all of this information is really important. With this research and our new health and wellbeing strategy in mind, let's work together to 1, reduce health inequalities, 2, treat everyone as individuals, and 3, think about the whole person, and 4, build on the positives. If we do this right, we can make Leeds a really healthy city for everyone, male, female, young, old, rich or poor, abled or disabled, gay or straight. And what makes us different makes us great. So let's celebrate that and build our services accordingly. Thank you.
Thank you for that. So I'd now like to ask Professor Alan White, Dr. Amanda Symes to come up and present their findings.
Thank you very much. Welcome. Thank you very much indeed. It's tremendous that so many of you come to join us today and that to hear about our report. We will split it a little bit. I'm coming in first. Amanda's going to talk about some of the data. I'll come back in. And there's a panel session at the end. So some of you may have questions. If we can hang fire with the questions until later, I'm sure we'll have plenty of time to quiz us on what we've got. Can I just start by saying that this is a significant report in that it is the first time a whole city. The Men's Health Forum with Steve, my colleague, Steve Robertson, has looked at Lambeth and Southwark in London. Others have looked at various parts of cities. But this is the first time we've looked at the whole city to see not just the problems of men's health, but the causes, because we're looking to see what can be done. This was commissioned to see what services could do to reach out and target men more effectively. Is money being spent wisely? And so the purpose of this was to say what's happening out there and how are services working with the men. We've done work around this area. We did the European State of Men's Health report for the European Commission, and those works are still available. If anyone's interested, please come back to us. So there's two main reports. There's the data report and there's the main report, which is the narrative of the data. And what you've got is the summary. In here there's a lot of information, and if you are interested in men's health, no matter what area, please have a look at these big reports, but be kind to the printer. They are big and they are on PDF and they're now available online, so please use them as a resource. We'd like to acknowledge the fantastic support we've had from Ian Cameron, Lisa Mulheron, and thank you for pointing that out. She's moved on, but her legacy, I think, has remained. Tim and Catherine Tim Taylor and Catherine from who have helped us throughout this from the council. The commissioners have been extremely supportive. That's the thing, a very important thing for us to say. This has been done with the full support. This isn't someone's done something separate and then imposed it or told the council about it. This has been embraced by the council, and I think that that is one of the most positive aspects of this, that you really feel it's going to be worthwhile. And James and Richard from the Public Health Intelligence team, my colleague Professor Steve Robertson, Gary Rain for their work through it as well. Rob Newton, who is a co-author, not speaking today, and Professor Robert West from the University of Leeds, who worked with us on a sister piece of work that we're not talking about today, but I'm sure will become available later on. Methodology, it was a literature review, an analysis of current policies and practices, so what's out there, what do we know, what's happening within Leeds, and then interviews with key council stakeholders to hear their perspective, to hear from them as to what they think are the issues. And there are a few quotes through the report, not many quotes, but their influence is evident throughout it. And then there was an analysis of routinely collected health, socioeconomic and service use data. And we broke the report down into the 107 MSOAs, middle super output areas. So when you look at the report, you can identify which of the areas has the highest number of men receiving benefits from this source or that source. Where are the men with the most problematic diabetes rates? Where are the men with the highest cancer rates? Down to a very local area. And I think that's another thing about the study, in that it does help the commissioners to think, are we actually targeting the men in the right place, in the right way? But when you look at that map, you fail to see the variety. And this is where we come into some of the problems we've got. We had a massive task on our hands, because who are these men? Where are these men? These men are boys. These are from birth right through to old age. And they are men who are boys engaging in all sorts of different things. And therefore you have limitations. We couldn't do justice to all of them. And some of you will be disappointed. You'll get the report and you'll think, you haven't said enough about gay men. You haven't said enough about ethnic minority men. But in many cases we were very limited by the data available. Because if it's not recorded, you can't report it. And so we have to accept the fact that what we've done is a stimulus, create a stimulus for others to follow on behind and say, if I'm particularly interested in this, this is the basis for people then to come on behind and do more work in that area. So it's broad, it's comprehensive, it's not complete. And I hope people take that as an indicator. And it's not a voice of men. We haven't heard the voice of men themselves. And we haven't really had a chance to speak to many providers, because the remit was to speak to the people who were commissioning and doing the data collection. So there's many voices we haven't heard. But again, why not next study? So the main message is city of huge variance. And it's not just the poor. It's not just poverty. It is about all men. Being 107 areas shows that there are men in affluent areas with many problems of overwork and stress and suicide, as there are in some of the inner areas. So alcohol rates go across the city. There are problems across the city. But there's huge variance, obviously, when you get down into the poorest of the poor areas. My goodness, we have a challenge with women's health, but men's health, it just hits you. Men typically have higher levels of preventable premature death and ill health. And Amanda's going to show you some of the data, and it usually comes as a shock to a lot of people when you see how that spans across so many of the diseases that should affect men and women equally. Our main message is that there needs to be a concerted effort to reach out and target men, and to work with men of all ages, from birth through to older years, so that they are able to encompass their health in a more positive way as well. So it's not victim blaming, it's about looking to see what's the issue and how can we work most effectively with men and most effectively with services, whether it's third sector, statutory sector, whether it's in education, whether it's in housing, whether it's in benefits, whether it's in employment, wherever they are. How can we work with all the people who come in contact with these 368,000 men in Leeds and boys and men in Leeds to make their lives healthier and happier, not just for them, but for their families, wives, partners, everybody.
So one of our starting points was obviously to try and understand a bit more about our male population in Leeds. So we have 18% of our male population are aged between from birth to age 15 years. 69% are what we call working age, 16 to 64, 13% age 65 years or older. However, that's across the city. So obviously, as we've already mentioned, there's a lot of diversity across the city. And looking across those 107 MSOAs, we have quite drastic differences in the spread of the population. So this just shows the number of people in different age groups. And this is an MSOA called Swillington, West Garforth, Little Preston. In that area, we have 26% of the male population aged 65 years or older, so a reasonable ageing population there. In the city centre, however, it's very different demographics. So 1% of people aged 65 or older, so very small older population. 68% of the male population aged 20 to 34 years, so young professionals really in the city centre. And just another example, Seacroft South. It's very heavy in the young person, so 29% of the male population aged 0 to 15 years. So obviously just in those 3 areas alone, the different demographics mean that obviously these people have different health issues, different health needs, maybe the way they access services are going to be very different as well. So these are one of the things that we need to think about when we're considering health needs of populations across the city and how that people access services. Our population's growing, so between 2004 and 2013, our largest increase in Leeds population was among older men. So on a positive side, this means our men are obviously living longer. That was a 10% increase. It does mean obviously having an older population, potentially more health problems are associated with older age. So this is something we need to think about when designing services for the future. And it's estimated that between 2015 and 2035, the older male population will increase by 46%. So again, positive, our men are living longer, but potentially they could be living longer with chronic health problems that require use of services. So again, going back to diversity, we have a changing ethnic population. So there's just a couple of age groups compared here. So 0 to 24 years, males and females, compared to the older population, 65 years plus. In the older population, 5% of the population across Leeds is of non-white ethnic minority. In the younger population, it's 20%. So obviously, as that population ages, we're going to have an increasing ethnic minority population. And obviously, within different areas of Leeds, we're going to have different cultural differences. And again, going back to people having different health needs. So prostate cancer is more prevalent in Afro-Caribbean men. This could be increasing in the future. Different cultures, potentially different diets, higher smoking in Eastern European men. So these are all the things we need to consider. And again, going back to the MSOA level, in some of these areas, we have more than 50% of the male population ethnic minority. So again, we've got very different demographics, potentially very different health issues and use of services. We looked at disability. So anyone who was affected with some kind of a disability that affects their daily activities, that limits their daily activities. So a disability or a long-term health problem. And obviously in our younger age group, there's still a reasonable amount of people, but the proportion's quite less. If we look for the 50 year and above, 36% of men have some kind of issue that limits their daily activities. So this might limit their employment opportunities. It might limit how they can access services. It might lead to social isolation. So again, these are things that we need to consider. So life expectancy, Beckett already mentioned earlier on, we've got a difference in life expectancy. So between men and women across the city, 78.9 years for men compared to 82.4 years for women. But we've already said this does vary, typically within affluent and poorer areas. Life expectancy at age 65 was 17.7 years for women. So from age 65, men can expect to live 17.7 years, 20.3 years for women. But it's estimated that men will live with a disability for 41% of those years from 65 onwards. So again, these are just things we need to consider, particularly if we have an ageing population. So with that life expectancy being lower for men, if we look at the age that men and women are dying in Leeds, we see very high numbers of deaths in men in the early ages, so what we call premature. So before age 65, we've got a very big increase here. So you can see that from kind of 25 years onwards, we've got a sharp peak or a spike in numbers of deaths in men. We see an increase in the number of deaths in women in the older ages just because these women are the ones that have survived younger age. Obviously, at this point, we've got less men who are living at that age, so then we see the death numbers in women start to take over. So that just really hits it home, the difference in life expectancy, I think, looking at this data here. And obviously dying before age 65 is quite young. So the causes of death. So what we've done is we've just compared the death rates for men and women across diseases from the most common. This is for under 75s. And what we can see here is cancers. So cancer is the most prominent cause of death. in men and women age under 75, followed by cardiovascular disease. So it's the most common for men and women, but we can see that for men there's a higher death rate. And if we look down across all those diseases and causes of death, they're always high for men. And really there's not really much difference, not much reason as to why there should be. So these should affect men and women similarly. Yet we've got more men dying from these diseases, which technically are preventable, as we said earlier. So the graph on the right just shows the ratio for each of these diseases and causes of death. So again, for each of these, if it's above 1, the male death rate's higher. And you can see for all of those it's above 1. If we come down to suicide, yes, the rate of death might not be particularly high, but the difference between men and women, nearly 5 times. So it's quite a serious issue there. We'll talk a bit more about suicide later. So looking at prevalence of disease, so these are people that are living with chronic disease, and again these are people who've been diagnosed. This is GP data, so obviously it's not going to cover everyone in the city. This is people who have had a diagnosis. So we look at chronic heart disease. We've got more than double the number of men than women with chronic heart disease. Cancer, we have more women who have a diagnosis for cancer. However, that's probably more to do with sex-specific cancers. So cancers that will more likely affect women, obviously breast cancer. Men do get breast cancer, but women are more likely to have it. And men have more aggressive cancer, so lung cancer, things that they're more likely to die of. We already saw that the death rates for men for cancer were a lot higher than women. Chronic obstructive pulmonary disorder, with similar numbers for men and women, but if we look at diabetes, 47% more male diabetics compared to females. And obviously diabetes is linked to heart disease, so this is something that we can maybe prevent then developing into heart disease if we get treatment early enough. So I've already said earlier on, the rate of death is 5 times that of women in Leeds. That is higher than the national gender difference, unfortunately. And although we do have, it's known that more women attempt suicide, more men actually die as a result of this. And this rate does seem to be increasing for men in Leeds. It's also very widespread in men compared to women. So it's not a case that more men in small pockets of Leeds are dying from suicide. It's more widespread across the city. So 74 areas of Leeds, 74 MSOAs reported deaths from suicide compared to only 25 for women. And again, we know more about women self-harming, but there's also quite a high prevalence of men self-harming. That varies across Leeds, and some of it could potentially be unreported. If we look at mental health, so again, out of those who have received a diagnosis from a GP, if we look at common mental health disorders, so anxiety and depression, much higher numbers in women. Now, some of this could reflect men not seeking help, men not receiving a diagnosis. Obviously, we don't really know. This is just what the data shows. But if we look in the severe mental health disorders, we can see high numbers compared to women for things like schizophrenia. So maybe we can do more to get more men picked up. And the data we saw showed that males were less likely to be referred into IAP, so improving access to psychological therapies, than females. And if we looked at the number of mental health bed days for males, it was 58% greater compared to females across all the clinical commissioning groups in Leeds. And 61% of all bed days were associated with males. So that's obviously once it's got to a chronic stage, we're seeing high numbers for males than women. I'll just pass back over to Alan, who will talk more about some of the underlying causes of these.
Why are men so much more at risk? What is the reason? It doesn't make sense in some respects, because most of the conditions are not sex specific. There's no reason why a man should have higher lung cancer deaths. There's no reason why a man should have higher bowel cancer deaths. So we have to come back. We have to step back, and we have to think about, well, what are these things called males? And we've broken it down into this the biological male, what were we born with, what's the biological differences between men and women, and then how are boys brought up, what's the messages given to boys, what's happening in schools, and how much are services working with boys and fathers and mothers to help the upbringing of their children, to look at their health in the longer term, and then what's it like to be living as a man now? What's it like to be a man in this society, in this city, at this time of the 21st century? And you can see that the anatomy of men obviously is important, the physiological processes, and I'm not going to go into it all, but there is some. But what stands out so markedly from our data is that it cannot be a biological inevitability. Otherwise, there would be the same throughout the city, and you wouldn't have these massive differences. So we have to look at a different set of factors, and we argue that the social determinants of health are so vastly important that we do a lot of work on the housing, education, employment, poverty of men within the reports. We look at the intersectional factors which you've started to see already presented through Amanda's work. Boyhood socialization within the report, we start to talk about what are the pressures boys are under? How are men dealing with a life that doesn't meet the expectation of a life where they are meant to be at work, where they are meant to be in a partnership, where they are meant to be active fathers? And some men find that a struggle, and they cannot be part of a family, they cannot be part of a partnership, cannot be part of work, haven't got a decent education. And there's structural issues about how policies are framed to reach out and work with men. And our obesogenic society and such like. And then obviously the lifestyle factors. I've got them down at the bottom because I don't want people to start pointing fingers at men saying you shouldn't be smoking or you shouldn't be drinking, because they're obviously caught up with something in their society which has created that as a need. And if 70% of men are overweight, 70% of men have not chosen to be overweight. They are not feckless in their diet. They are people who are living a life, and we have to be working with them to be more creative. So social factors impacting on men's health. We know that in less affluent areas, the city have significantly worse health than those living in the affluent areas. But as I said before, that's not exclusive. No man can be complacent. This is a wordle, which we did for the we had lists of all the different things that came up. The area with the highest level of benefits, the worst education, the biggest health challenges, and you can see common features of the places, if you know Leeds, West Hunslet and Hunslet Hall, Skipton South, Lincoln Green and Ebor Gardens. These are areas where there's high levels of deprivation. So it does stand out that we have to look at the inequalities aspect of Leeds to make a difference in the long run. We were staggered when we looked at the housing. 1 in 5 men live alone. Nearly 2/3 of residents in the council-owned high-rise flats are male. This type of housing can be linked to high levels of depression, self-esteem, low self-esteem, mental health problems. Typically of working years, yes, but when you've got in 3 areas, Lincoln Green, Swinlow and Bramley, 70% of residents are male, which suggests that the council tax, the one-bedroom tax, is pushing people. And when we talked to the commissioner, something that came out strongly was these are invisible men. These are men who are on no one's radar. They don't account for any kind of beneficial housing, or there's nothing that stops them being herded together. And we're finding now that there are areas where there's real problems of social isolation in younger men as well as in older men. We were at the Crypt before filming, and we had real issues about the number of homeless men. Nearly all the homeless in the city are male. Not all, but nearly all. Education, this is a factor that has to be seen as significant. Percentage of boys in Leeds of all those eligibles achieving level 2 in Key Stage 1 was 77% compared to 87% for girls. Reading, we were looking at over 70% of boys not achieving reading level 2 in 3 MSOAs. So they're starting out with a major disadvantage. But we already know that boys are achieving less GCSEs. We know that less boys go on to university. And we see this in the adult population. We know there's a lot of women that don't have education. But we also saw in some of our areas, more than 30% of men had no qualifications whatsoever. Employment. Nearly 70% more men than women in Leeds registered as unemployed. Now, I know there's issues about many women not putting themselves forward as unemployed, but it was still a stark fact when you look at facts about this 70% more men being labelled as unemployed, 60% more men than women who are workless for more than 2 years, labelled workless, and of those in work, 3 times as many compared to women work at least 49 hours. So we've got two extremes. We've got a group of people who are seeing themselves as out of work and wanting to be in work, or are out of work and labelled as out of work. But we also have another end of employment, which is where we have high numbers of men who are working excessive hours. And the stress that goes alongside lots of jobs is now creating quite a challenge. And that's 17% of all men in work. Fatherhood is a fantastic opportunity for men. It's a really significant part of a male's social process of becoming a man and having a place in society. I am a father. And yet you find that when we looked across the city, this number of services that were reaching out to these guys was limited. But there was also limited data. But what we did find, which was interesting, there was over 2,200 lone fathers with dependent children. And when you think that there's over 10,000 babies born in Leeds every year, that's a lot of new fathers. And yet there's still no real talk of fatherhood and services for fathers and toddlers, fathers and boys, girls, whatever, as an issue. Carers is another area of hidden maleness, which I think is something that the report hopes to bring out. 30,000 men in Leeds provide unpaid care, with 6,500 men providing 20 plus hours of unpaid care per week. But when we did manage to speak to some of the agencies that was supporting carers, what they said is it's almost impossible to get men as carers to come forward for support. And so there's a real issue about how many men out there are doing a huge amount of unpaid work, which they don't see as unpaid work, they just see as caring, and therefore they're missing out on a support level, which perhaps would make a difference for both them and the person they're caring for. Lifestyle, we have more men overweight than women. There are more women obese, but in terms of totality overweight, and men's weight tends to be visceral, which increases the risk of heart disease, diabetes, hypertension, high cholesterol, and the fat-related cancers. Smokers, we still have more men who are smokers. We have higher numbers of men who are risk of alcohol. And though we know the narrative about women and physical activity, and a lot of effort is getting women more active, there is still a huge number of men who are inactive. And I think that's something that we fail to really latch onto. When we look at this, though, most of it is unknown. We're very good at smoking. Only 6.5% of male smokers are not known whether men know if they smoke or not. 21% compared to 9.2% of male weight. We still have very poor data on how many men are actually overweight. But when we come to alcohol consumption and physical activity, we're finding the majority of GPs are not collecting data. And that makes it very difficult for us to be able to make any kind of serious statements about how many men are actually at risk. At least 10 MSOA's weight status is not known for over 30% of men. So that's a lot, because these guys will be going to the GP at some point, and to have no record of their weight makes it, you realise that actually perhaps it's seen more of an issue for women than it is for men, but we have more men overweight, and perhaps there's a mismatch there in terms of perception of risk. Alcohol, we have some of the highest rates of alcohol admission and mortality in the country, and it's a serious concern about how alcohol, the risk of alcohol is recognised within the city. We're in the highest 20th, 264th out of 326 for male alcohol-specific mortality. Smoking cessation, sometimes there is a real attempt to get men engaged, and I think the city has to be recognised as doing well in many areas, and smoking cessation are seen as a beacon of good activity, good work. And yet we have, when you look at the number of people who are registered as a smoker, these are the males, and you look at the number of people registered with the smoking cessation service, we see a mismatch. Now what's interesting is when you actually get the men to smoking cessation, they're more likely to give up. And so the effort that the council's putting in is worthwhile, but we have to think whether we can do more. Weight management, this is the number of people who have got a weight problem, and this is the number of people using weight management services. And you see both the low levels, but also how few men in comparison to the risk actually are engaging in the service. But when we've run weight management services in male-specific ways that have been really focused on men, we've had a lot of men engage and a lot of men lose weight. So it can be done. It's not as if this is an impossible task. Bowel cancer screening. Men have double the rate of death from bowel cancer, and yet women are more likely to complete the freely available NHS bowel cancer check. But when they are screened, more men are diagnosed. So if we're able to get more men to get to screening, to complete that fecal occult blood test, then we would have more men diagnosed earlier and treated and lives saved. NHS health check. We've seen that men are at higher risk of cardiovascular disease in the early years, and they have specifically tried to get more males engaged, but you still find that when you do, fewer men take part, but when they do, more men are picked up with problems. So the effort is worth it. The effort is worth it. Domestic violence, we had to put something in the report about domestic violence, and it was impossible to get data really to reflect the risk both to men and to women, because we recognise that men are both perpetrators and victims. But what we did find is that there is an almost complete dearth of services that are trying to stop men being violent. And men would be leaving one family and going into another family with no intervention, no opportunity for anger management, no opportunity for dedicated services to work with them, use expertise to try and turn around that behaviour. And there's almost no services that are available for men who are victims of domestic violence. And it's part of the narrative, and we have to be ready to embrace that narrative about men as victims as well as perpetrators. And even the men who are perpetrators, when you look at the literature and what's been written about it, how much of them are damaged individuals that we should have picked up earlier and worked with them sooner to prevent the horrific actions occurring. The experience of commissions, some of the quotes: vulnerable men. These men are mostly invisible unless they are a nuisance. And I think that's very telling, isn't it? That you have perhaps a lot of sad young men or old men that are just invisible in the system. They don't flag up on anyone's system. Insight work, which was part of the suicide. One of the commissioners commented when they were doing the interviews and work for that, they were talking about these apps, and they said, it's like I haven't even got a smartphone. I've got a basic bog standard one. That's how crap I am. And it sort of really hits home that we can have these highfalutin ideas, but sometimes just walking out and talking to people is a nicer way of trying to communicate than getting them to engage in something technological. Men entering drug system mainly through the criminal justice service. So all those men that we're concerned with, the majority of men who engaged with the alcohol services were pushed there by police, criminal justice service. So are we really effective at reaching out and targeting men and working with them when they've got problems with alcohol? Perhaps not. There is some fantastic work in Leeds, and we have to rejoice in what's been going on. The Leeds Men's Health Network, and we've got Barry Hewitt, and we've got some other members of the team here, they've been pushing for men's health for years and years. It's one of the first cities in the country ever to have a push for men's health. And I commend them for their work, and it's been a hard slog over the quiet years. Hopefully this will be a stimulus for more things to happen. Errol's not here, but the Dadtastic Day is coming up. We've got the Wortley Men in Sheds. We've got the Rhinos work that we did and now is continuing. We've got Darren, who's going to be talking with us later on around the men's groups that have now been set up. We have got some fantastic work. And the council have been doing great work. They've been commissioning services. The CCGs have been commissioning services. And I think we now have to grasp the opportunity and push forward. But, and the but is, that this is not where men's health sits or lies or stops. It has to be across the board. All services should be recognising the importance of men's health. And we look to policy, because policy is the driver for a lot of this. And if people aren't told to do something, then will they do it? Well, actually, there is a legal requirement now through the Equality Act for all services to be meeting the needs of men and women and other protected groups, but men and women. So we have to be thinking, if we're producing a service, how is that actually working for men? When we looked at the policies, we realised that actually perhaps that wasn't there. Perhaps that push wasn't there. Perhaps there is more that needs to be done to make visible men's and boys' health needs. But it is so encouraging to have worked with the council and to see in the new health and wellbeing strategy that it's been included as an important issue. And I think that that now is a stimulant perhaps for future work. When we look to recommendations, there are many in the report, and each section has its own series of recommendations. We try to pull out some global ones. To be able to give it some pointers, more general pointers. So these are the ones that were in the pamphlet, the summary document, but perhaps for people to think about. And one of the ones that we want to think as the most important is that we stop talking about the population in any documents. We start talking about men and women. When we stop talking about children, we start thinking of boys and girls and what is necessary for us to do with boys that is different from girls. And we stop talking about parents, we start talking about mothers and fathers. So we have to start thinking about what is the impact of this on the father as well as on the mother. And what are we doing with the old, and what are we doing older men, younger men? What are we doing with black ethnic minority men rather than the black minority ethnic population? See how it works? You've got to think about it in terms of who these people are in a much more nuanced way. In all planning, Leeds should consider how services should be better developed to better meet the needs of men. So if we're looking at smoking, what is this for men? Services and Leeds should develop specific guidelines on how to target men with greater use of integrative service provision. I meant to mention that before. One of the things that came out from the literature was when you just take a man to a smoking cessation clinic and then tell him to come back a week later to an alcohol clinic, and you tell him to come back a week later to mental health, you've missed him. If you go to the mental health clinic and while he's there he is having his smoking and his alcohol issues addressed at the same time in an integrated way. The Crypt has got a Men's Health Week this week, and the services have gone to them. The men don't have to go out. The services have come to them. I think some of the best work that is now occurring in the city is where they are working with the men in the communities, in their safe settings, their comfort zones. Investment should be considered a high priority in those areas of Leeds where men's health issues are most pronounced. With this report, we can work with the public health team and we can say, this is where we need to be thinking specifically about putting smoking cessation or alcohol or mental health. Why are we then not trying to commission services around that need? And I'm sure actually it will be occurring, continue to occur in many instances. Boys' education is the foundation for their lives, and yet so many boys are missing out on a good level of education, and I think that that's an area we need to be thinking of as an absolute priority. Employers, wherever men are really, I mean Leeds Council is one of the biggest employers of men. Leeds Beckett University is another huge employer of men. Large employers of men should be thinking about what are we doing for the male workforce? And also, how can we help those men who are now no longer in work or being made redundant? Community groups that have been successful should be supported, and they should share their DNA, that we should learn from them. And we know that already, that there's many third sector groups that are really successful, and we should be thinking about how can we emulate some of that work in different areas. A men's health campaign would probably help, even if it's just to mobilise more people like yourselves to think through men's health issues. And partnerships are needed with religious groups to really help all groups in Leeds to think about men's health, because this means them as well. So what are the next steps? We have to improve routine data collection. This city is brilliant for data. I've been to other cities and they have very poor data. They have fantastic quality of data, and yet it still leaves massive holes. And we need GPs and other people who have got responsibility for collecting data to do it justice. Because without data, we are talking about an incomplete picture all the time. We need to have targeted research with minority groups. We need to be thinking through how these other groups of men that have probably missed off the majority. But having said that, the biggest group of most worrying group at the moment are white British young males. And that is not a minority group, that's a majority group. That is a majority group which have real issues, and yet most people are missing them because they are off the radar. And we have to explore men's experiences of services. People tend to develop services, put it out, men don't turn up, and then question why. We need more research. What's working? Why is it effective? And how can we use that in future planning? And we have to have an analysis of primary care data to explore men's use of GP services. I think that's a real crying out. That's one of those things that are crying out to be done. What's the question? And it's fitting we finish on this note, because men's health affects women and women's health affects men. And we are not talking about men and women, we're talking about gender. And we're talking about the fact that gender matters, and that we don't yet have a full picture of women's health within the city. And that by having that picture, similar to what we've done with this, perhaps we can then truly start to look at whether services that are being provided are reflective of the population. Thank you very much.
How do you follow that? Thank you very much, Alan, for giving us your insights. I can only give you all, I'm trying to lighten the mood a little bit really. There's some really serious stuff there. I think the one piece about... I was just going to say, you know, as a 52-year-old man, I sit there looking at Alan's charts and killer statistics through my hands almost, you know. It really brings it home on a kind of personal level for yourselves and many people in the room, perhaps, not least for the citizens of our city. Right, really compelling stuff, I'm sure you'll agree. And Alan and Amanda and colleagues have spent a year gathering and looking and interrogating data and turning that into intelligence. And now the challenge for all of us is to look at that intelligence and do something, isn't it? Because what Alan has shared with us requires a response. So it's timely, I think, perhaps to give you the opportunity in true Vox Pop fashion to ask some of the people who are going to come onto the panel or tell them what you think the response should be, or even ask them what you think the response should be to that. So one at a time, would you like to come up to the panel and show your appreciation? We've got Professor Alan White first of all. And you know Alan already. We've got Amanda, Dr. Amanda Seames next. Amanda, thank you. Now we've got someone who I think is in the audience, Damien Daughtry, who is from Space 2 in Leeds. Damien. Just tell us a bit about yourself, Damien, please.
Okay. Hello everyone, my name is Damien Daughtry. I work for the Orion Consortium, which is a partnership of charities in East Leeds working in deprived areas there. And my role is to research and develop activities in engaging vulnerable and isolated men. We've set up a programme of groups in that area.
Thank you. Ian, would you like to come and join the panel, please? Dr. Ian Cameron, who commissioned the work, of course, and one of his team, Tim Taylor. Tim, thank you. Tim, would you like to just tell us a little bit about yourself, please?
Yeah, sure. Hi, I'm Tim. I work in Ian's team in the council, and I suppose it was my job to look at what we as a city might do about men's health. It was seen as one of the gaps in the Joint Strategic Needs Assessment, so that is a document which talks about all the data about the needs of people in Leeds, and men's health is seen as a missing gap. So I met Alan and it started from there, really.
Good. Right. Lots to go at. We've got 2 microphones. 1, 2. Thank you very much. Gents, we've got roving mics. If you have a show of hands, I'll take a couple of questions. Tell us who you are. If you're here representing an organisation or anything, then let us know. You might just be here as a resident of Leeds, of course. And we'll see what we can get our panel engaged with, if that's all right. So who's first? In fact, one thing I will say, sorry, we've got a mixed audience here. And I know there are a lot of academic colleagues. What we'd love to try and avoid is kind of getting into some methodological inquisition about that, you know. So if we can try and leave that for the coffee, and later this man and Amanda will look after all of that, that'd be lovely. Yeah? So thank you very much. Let me have your hands. We've got one at the back here first of all, sir. Thank you. Man in the black shirt.
Thank you. My name is Beckett. I work with Touchstone, charity in Leeds, mental health and wellbeing charity. First of all, I would like to congratulate the team for this groundbreaking research, detailed, it's mind-boggling. I was taking notes, tweeting, and I think there's a lot that we can use. And also, this is brilliant, especially looking at the panel. The academia, the practitioner, people on ground from Space 2, and the commissioner sitting on the same table. And I think this is a good starting point for all of us to start working together and delivering on the recommendation and what comes out from the research.
Thank you for that.
Thank you.
Thank you for your observation, Derek. No question?
No question.
No, just a nice observation, telling us what you think. Thank you. We've got another lady here at this side.
Good afternoon. My name's Heather Nelson. I'm the Chief Executive of Black Health Initiative, so I know some of the panel members very well. My question is on behalf of the third sector, I suppose, there's been for many years lots of good work that's addressing some of the issues that were highlighted and are highlighted in the report, which again is excellent, and we can use that as part of a tool to continue looking at commissioning. But that's my question. The good work that often starts often have to end within a set time period, even though it's showing immense impact on those who we're working with. The only way, in my opinion, for it to have actual effect is if you continue to commission those effective working partnerships and working ways. The specific community-based MOTs, as what BHI has, and others, is obvious, and it shows that it works. When will we be able to continue doing continuous good work instead of having to do a 1-year period, 2-year period, and then start again?
Thank you, Heather. That's a Oriel chestnut, isn't it? Short-term commissions. We'll come to that. We've got the gentleman down here in the second row from the front. Simon, thank you. And just while we're doing that, who's going to be next? James, I'll come to you. Okay.
Thank you. My name's Andrew Howarth. I'm Head of Patient Experience for Leeds and York Partnerships. Once again, congratulate you on the work, and I'm looking forward to seeing a bit more of the full report. There's some excellent stuff going on. Alan, some of my team were involved with you earlier last year with our campaign called the Man Up campaign, where we were trying to raise awareness of men's mental health issues. And I'm just wondering whether it's something that public health could take on in the same way that we had the Time to Talk campaign, that there is a definite need still for awareness raising around men's health issues, and whether there could be some kind of public awareness campaign on the back of that that just gets men to talk about mental health.
Thank you very much for that. So I've got a question on third sector short-term commissions and one on campaigning. Thank you very much, Andrew. I'm going to ask the third sector, would Damien like to get us underway? Thinking about, have you experienced this kind of short-termism in terms of commissionings, and have you got any good pointers you can offer?
Well, good pointers for short-term commissioning.
No, how to avoid it or address it from a third sector perspective. Is it something you experience?
Well, yeah, I mean, well, it is. I mean, I myself, I'm on a 2-year contract myself, and some of the men's groups we've set up there for a year, but obviously we look for them to get commissioned further. The Space 2 men's group, that started about five years ago, and that took an awful long time to build up its personnel, its participants. And if it hadn't been for the patients that were shown it by funders, then that wouldn't be there today. But today that's got 18, 20 men on the books, 12 regular attendees. So I think patience is, I agree with Heather that you need to look long term, and patience is definitely needed, yeah.
Thank you. Ian, would you like to add anything while we're on the third sector?
No, I entirely agree about the problems of short-term contracts. I must say I personally don't like short-term contracts, and we are moving to make contracts longer. But I think your question was broader than just the length of time of contracts. It was also about evidence of what works, and that is in some ways a holy grail to get at. But you know, we, the commissioners, guys, we've still got to continue to work together to provide the evidence of what works. And that is going to be increasingly important, quite frankly, as budgets are getting more and more difficult. And I think also on the evidence front, I think we have got to be upfront about when we can demonstrate that something isn't working. We've got to be bold and be prepared to decommission services. So I think you're asking an extremely challenging question, but in terms of your core one about length of time of contracts, I entirely agree with you.
Alan's just given me a prompt. He's got something to say to your question there, Heather, I think.
Bradford Health of Men set up a wide range of initiatives with men's health, and Nigel Hughes was in those days part of that. They set up a weight management group for men in a factory, and more women turned up. And they set up a health information centre for lads in the town centre, and no one turned up. And well past the time when they would have been decommissioned by, well, no one's coming, they then got lots of people coming, because the way men use services, word of mouth is so much more important. And it's got to be seen as credible, and they've got to have confidence in it that there's going to be to their needs. And it's so important that when we're commissioning services for men, we're allowed to give it time, because a lot of men find it a real struggle to use those services. And I just wanted to apologise to Heather. Your work, why I didn't have it, I think it was on the slide, I just didn't talk about it. So anyway, brilliant. Do you want the Man Up campaign? Brilliant. I mean, the men are hidden. Their mental health problems are hidden because they're not engaging, and they're not engaging because there's still this huge stigma about talking about problems and what the consequences might be. And we are getting better, but we have to keep badgering, hammering to get change. So anything that we can do to support the campaigning for mental health, especially in Men's Health Week, which is based around stress this week. Fantastic. Thank you.
Thanks, Alan. Damien wants to come in here.
I just want to say, I think it's also important to try and build in peer support into your work as well, to try and create that longevity and sustainability. It's a pity El's not here because
he was their father. So we're meant to have a father here as well.
Yeah, he runs Leeds Dads, and that's an entirely volunteer-led fathers group based at the Tetley. So
I'll come to your question.
A great example there of that.
Yeah, Tim, just thinking about campaigning, it's a recommendation from the report as well. Who's going to pick this up? Where do you think that kind of naturally sits for someone to provide the lead and get all partners together in terms of a campaign around men's health?
I mean, been some really good examples of campaigns locally. I'm just looking at Catherine and some of the crisis cards that we've done around suicide prevention, which we took to kind of non-conventional places. So we took them to betting shops and pubs and community centres and places where people are rather than places where we'd like people to go to. And I think one of the things that comes out a lot in Alan's report, which is we expect people to come to a certain building sometimes, and actually if you go out to them, you've got far higher rates of engagement. There's a really great project happening in the west of Leeds at the moment in some of the tower blocks where we've got 78% men, and we've got an outreach worker who's working in these tower blocks in New Wortley. And she's doing some fantastic work. These people have got really, really difficult lives, and sometimes it's not about just expecting people to come to us, it's about actually reaching out to them and the whole idea of co-production as well.
Thanks, panel. Heather, any observations on your responses? Are you happy with that?
I think I am. There was an endorsement in regards to it does take long to do targeted outreach that's effective, because it does take a long time to get the men to actually build up the trust with you, and hence the issue in regards to short-term funding, because by the time, if it's a 3-year contract, it takes 18 months perhaps to get men to come, and then your workers looking for another job because obviously they need that, and we then lose the whole momentum. So we do seriously need to look at the short-term funding issue.
Thank you. And I think the lady in the white jumper wants to make a response here. Simon, please. Thank you. Tell us who you are, where you're from.
I'm Trudy Silman, and I'm a trustee of the Leeds Older People's Forum. And as most of you know, we now actually are involved with the Time to Shine, and we are offering, or able to offer, some short-term contracts to people, or partnerships I think is the right word. So we should make people aware of this, and hopefully these short-term things will then be able to carry on and do more work.
Thank you. Next questions then, I've got James up there, and then I'll come to you soon. Yeah.
It was a question for Ian, really. Ian, to what extent did this report come as a surprise to you in terms of the data that was presented about men in Leeds?
Could you just tell us who you are and where you're from, please?
James Woodall. I'm a reader in health promotion in the university here. So yeah, to what extent has the DPH did this come as a surprise? And secondly, given the context of cuts in public health nationally, what extent are Leeds City Council able to implement some of the recommendations of the report?
2 questions, Ian.
Thank you very much. Well, in truth, a lot of the information wasn't a surprise, but of course what we got is actual Leeds data, and that is what is valuable. And I think the way that Amanda and Alan presented the data against the MSOAs, the particular geographies of Leeds, makes it a much more powerful document than if you were perhaps looking at some research and a Portsmouth or something and you're trying to extrapolate it to Leeds. So I think the huge value of this report is that the data is Leeds. In terms of help the document is giving, it's also identifying where our weaknesses are around data. Alan and Amanda have done a fantastic job looking at all the data, what there is and what there isn't. And I think that provides a very powerful message for us and links into Alan's recommendations. So, Alan's been talking about primary care data. We've got to start looking there. So there's a huge amount of information, value for us in Leeds, because this report has been done on Leeds. In answer to your second question, there's no escaping the fact that the government has announced cuts to the public health grant. and it is having an effect on us. I'm not going to pretend otherwise. Alan has set out a series of recommendations. One on there, just one, is around hearing more about men's experiences and the voices of men's own experience of using the services. Now, that seems to me a really important next step that, you know, speaking of personal capacity, I want to make happen. But at the moment, I'm confronted with having to save £3.8 million this year, which is extremely difficult to do, and that is having an impact on existing services, as people know. So I'm not going to pretend to you that the cuts are providing a challenge, but I am very keen for us, in whatever way, working in partnership with others, whether we can look for funding elsewhere, to push forward these recommendations.
Thank you, Ian. Next question.
Can I just say something?
Amanda, please come in. Yeah.
In terms of the data, so Ian said he wasn't surprised by what was found. So we did find that when we spoke to the commissioners, they were aware that men weren't engaging in services and that men had greater health needs, but they didn't really know what to do about it, or they didn't have the in-depth detail that we had from the data. So some of the data is publicly available, some of it wasn't. Data is quite difficult to get hold of sometimes, and it's also quite complex to analyse. So obviously, by doing the report, it meant that the data that was available or that was obtainable did get looked at in detail to kind of provide some evidence to go with what the commissioners were thinking actually when we spoke to them.
Thanks, Amanda. I haven't done a good job because I've not kept us to time, but we've got everyone's attention still, so I'm going to keep going if that's all right with everybody. If you do need to leave and catch a train, then please do, and thank you for coming. But we're going to take a few more questions. We'll go here next, please.
It's not so much a question. My name's Tom Senior. I work for Health for All. I run the Young Dads project with the help of a lot of the young dads on the project, and we're working mainly in South Leeds. Initially, I just wanted to back up what Heather had said, and I think so many people in this room will share that sentiment, how there needs to be longer-term contracts and there needs to be more money going into these areas, despite the fact that we're living in times of austerity. That needs to be rejected personally for me. It needs to be a concerted effort from everybody, whether you're working at ground level or whether you're working up in university, council, government. Everybody needs to work together on this to actually even begin to alleviate these problems. My job would not have existed if it hadn't have been for charitable funding from Esme Fairburn and other bits of funding that I've managed to claw together. Some actually has come from the council, local council committee, but the majority of it has been again to charitable bodies. So something needs to be done about that. But the job that I am doing has brought people like Mark on board, and we were talking about the value of word of mouth. Without Mark helping me, this project would not be anywhere near as successful as it's been. And this is a young man, a young dad, who didn't used to be there to catch a bus, should we say, a little under a year ago. He's now assisting me actually running projects, workshops. He's catching trains to London, he's catching trains to Cardiff as part of the Boys project. So this work is so important, and he's inspiring other dads, and that is a chain reaction that we need to continue happening, and more money needs to go into it. And I'd like Mark to have a little few words with you as well, because I think you deserve to hear from him, because it's horse's mouth type stuff. Sorry to call you a horse mouth, but you know.
Well, just before you do that, thank you, Tom. I'll put a general observation to the panel. I'll just give them a chance to think about third sector engagement. Okay, and I'll come back to you as a kind of broad theme in a moment. But please go ahead, Mark.
I'm Mark, 23, got a young son, and if it wouldn't have been for him and knowing about it off my mate, then I probably wouldn't have been doing all. But now it's I'm with other organisations. I'm trying to start my own business. I'm helping people out who don't really want to community or they don't want to talk to no one. But we're just doing it that far, so I'm having to speak to them and trying to change their minds and change their lives, and it's really happening now. And all thanks to him.
That's all right. Good on you. So, panel, I might come along the line, all five of you this time, but third sector engagement, how important it is in the context of what we've heard today, and what needs to happen?
Very important. That was a really moving story, so well done. It's taken a lot of guts to be able to do that today. I think the third sector in Leeds is brilliant, and having come from different areas coming into Leeds, you realise how diverse and how strong it is. But because it's such an important resource and we're going through austerity, we really need to protect it. I think this piece of work that Amanda and Alan have done is a fantastic way of writing bids for third sector organisations in Leeds. And very recently, some of the women's organisations worked in consortia and have brought a few £1 million into the city. And it would be fantastic if we could do something similar with men's health. So, you know, it kind of tells you what the issues are, it tells you the right approach. It's almost a business case in itself. So, you know, I think we really need to support the third sector, and especially in this kind of developing area as well.
Thank you. Ian, I've worked in the voluntary sector before, and one of the challenges I had as trying to win commissions was I was up against big corporate companies who had lots of people who were very good at writing bids. And that's maybe a big challenge. I'm getting some reaction there, sorry. You know, and I'm not saying there's anything wrong at all with there's a place for Bupa and Virgin Healthcare and all of these, but when you're an organisation like Tom's, for example, or Damien's, how can we help them, you know, get the right information and a quality way in front of people who are looking to commission services?
Well, just first to say I entirely support what Tim has said, and I think you'll find that in terms of how we in public health in Leeds City Council use our funding with the third sector, we spend a huge proportion of our funding with the third sector, and we definitely value the small local services because, you know, our experience is those are the services that really understand the needs of individuals much better than the big corporation. So I think we've got an excellent track record of working with local third sector services. Looking ahead, it is fair to say that there is a move towards commissioning on a grander scale, bringing budgets together in a way of trying to make the commissioning process more efficient and effective. And clearly there is a move to pushing and working on a consortia basis. And I'm sure many of you have got experience in Leeds of working on a consortia basis. But all I can say to you is quality is our prime aim when we commission. It isn't about going for the cheapest at all, and we really value the strengths that the current voluntary sector provides in Leeds.
Thank you very much. Damien, any observations as someone from the voluntary sector yourself?
Well, obviously I'm going to echo the approval of the third sector himself. Yeah, I think well, this report is excellent in that it gives us the stats that we need. But I think in reading that report, I think a lot of us in the third sector will read it and will say, oh yeah, like I know that man, I know that person, I know that bloke who's in that flat. And the fact that we know that is because we are on the ground working with those people, and I think the more we can channel the money to those people working at really localised levels, as Tom is doing with your volunteers and that, for example. I mean, I think that's better because that's where the real connections are made. That's where the proper conversations are had with men about their health, and it's in when we build up trust. That's when we can actually make a difference to people's lives.
Okay, thank you. Amanda, have you got anything to add, Alan, or should we move on to the next question?
I echo.
Okay, I'm going to take two more questions then, colleagues. We've got a gentleman at the back there, Simon, at the end of the third row there, along from you. Yeah. Is there anyone else? And then I'll come to John. Thank you.
Yeah. Hi, my name's Matthew Osborne for LY PFT. It was just looking at the next steps we were saying, exploring men's experiences. I guess number one, how do you do that? And then whether it's a question or an observation, how do you kind of avoid the stereotypes? I'm a man, I'm just not really bothered about football at the moment. And I think sometimes when we try to look at men's experiences is where do you go to rugby, go to the pub. There's lots of men that, you know, that's where you're going to capture some men, but not all men's kind of experience. And being a teacher in the past as well, again, how do we avoid stereotyping children? Someone who's going to be expecting a baby daughter, it's really kind of come to me to start to think about how not to stereotype girls. So I was wondering, how do we start with that with children?
Thank you. Hold that one for now, Matthew. We'll come back to you. I'll ask you in a minute, Alan, to kick off. And then John, last question. John, please. Just in front of you here, Simon, please.
Thanks, Chris. I thought I had a positive end note to end on. We've just finished our step challenge here at Leeds Beckett. Many of you, the Leeds Beckett staff, probably taking part in it. Breathing a sigh of relief, you don't have to count steps anymore. But we engaged Alan and Amanda at the end of last year. We only had 18% of participants in last year's challenge were male, and we were determined to do something about that this team. That didn't feel right. And we engaged them, along with Jim, I noticed at the back there as well, in a conversation on what we have to do to get more men to take part. And the advice that they gave us, we took on board, and we increased male participation in this year's challenge by 89%. We had 110 more men taking part this year than had we had the same proportion taking part last time. So thank you very much for that. Very privileged to work alongside colleagues as knowledgeable and so willing to share their advice to make our jobs that much easier. I did have a very quick question though, is what more can we be doing? And I'm quite interested in whether there's any lessons from the work that Damien does or anybody else in the third sector that we as employers can learn about engaging men in primary health interventions.
Lovely. Thank you very much. Both questions about next steps. So Alan, next steps in terms of men's experiences avoiding stereotypical approaches.
It's a major worry about stereotyping, because people start to think about men's health and they think, oh yeah, we know about men and therefore we'll do this and we'll do that. And actually, if you look not too recent past, we've all made those mistakes and we've all gone down the stereotype road. And as we get more into it, and this is why I think people now need to read the report and recognise that we've moved such a long way in our understanding. We have a whole research centre at Leeds Beckett dedicated to men's health. Steve Robertson, our colleague, my colleague, has done a major piece of work on men's mental health. We've done work around men and weight. All these different areas we've looked at are recognising the nuanced approach works. There are differences between different groups of men, and we have to have social marketing, we have to be thinking about who we're targeting, we have to be reaching out to those men and targeting them. I keep saying this, reaching out and targeting those men, not all men, because it's a nonsense. All men are so different. That's what my first slide of all the men was showing, that diversity. So it's a worry, but we can do something about it. So it's a good question, and it's very apt that it's asked in this environment. As for what can we do, well, we just have to keep going. We now know where we're going. We're starting to learn, and we're starting to get the recommendations. And Damien is a prime example of where money will follow good ideas, and where CCGs are now receptive in a way that perhaps 10 years ago there wouldn't have been any chance of a bid like that getting through, whereas now it is getting through. And so we can learn, and separate conversations with all the people that are in this room who are obviously here because they're interested means that we've made a massive step forward in the way we understand men's health and what can be done in a city like Leeds.
Thanks, Alan. I don't know if Ian or Tim wanted to respond on the employer engagement aspect and what you think could be done or should be done.
Well, I was just going to, as I know this is coming to the end, in terms of your question about the engagement is, I would urge people to look at the report, the full report. There really are some fantastic examples in there of work that is going on in Leeds, and I'm sure you will not know everything that is going on in Leeds. And I think there are examples in there that might just stimulate your thinking and think, I need to speak to them and see how they've done what they have done. So I would urge people to look at the full report and get the most out of all the work that Alan and Amanda has done.
And on that point, I'll bring things to a close. Thank you very much, Ian. I wonder if you could show your appreciation, first of all, for Ian Cameron and his team, who commissioned the work from the city. And then finally, just before I say one more thanks, you don't have to dash off. There are refreshments outside, and so Alan and myself and others from the university would love to continue the conversation with you. Can I finally just pay tribute to my colleague, Professor Alan White, and Amanda and Rob from the university, who have delivered this seminal piece of work, I believe. Thank you very much.